Well, hi, everybody. Welcome to our webinar. We'll start in just about 30 seconds. Okay, well, let's begin. Good evening, everyone. My name is Rosemary Hunnam. I'm the director of the Sandra Rotman Center for Health Sector Strategy here at the Rotman School of Management. And our center is proud to host today's panel event, Designing for the Future, Evolving the Healthcare Supply Chain to Support New Models of Care. Although this event is taking place virtually, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, while we are meeting virtually, Toronto is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So hello, everybody, and welcome to our panel event focused on the future of the healthcare supply chain as we look beyond COVID. We have a terrific program lined up for you tonight. We're going to talk about the role of supply chains in supporting integrated healthcare delivery and creating better value for our healthcare spend. Our event tonight has two parts. We'll begin with a presentation from David Yunt, the president and CEO of Plexus, a leading not-for-profit healthcare supply chain services organization. And then we're going to move to a panel discussion moderated by David's colleague, Andrea Englert-Rigas. She's the Chief Procurement Officer and Vice President, Customer Relationship Management for Plexus. So allow me to introduce David. David has led the organization since it began operating in 2006. During his career, David has developed and implemented innovative business solutions in a variety of industries that include shared services, healthcare, consumer products, third-party logistics, distribution, and pharmaceuticals. David sits on several boards and is a graduate from industrial engineering at U of T and our director's education program from Rotman. Before I hand it over to David, I just want to mention our center is supported by the school and the Rotman family, and we focus on three main areas: research and thought leadership on health sector challenges, educational programming for emerging and senior leaders, and outreach activities like this one, which we design on behalf of our students pursuing careers in healthcare management. I'm going to put a link in the chat, so do check us out and follow us on LinkedIn for the latest in our faculty research, our programming, and our events. So thank you all for joining us tonight. And now I'm going to hand it over to you, David.
Thanks, Rosemary. Before I start, I do both personally and on behalf of Plexus want to recognize the loss of Will Mitchell, both to Rotman and to this program. He was a big supporter, and his leadership will definitely be missed. So I'll keep my remarks relatively brief because I'm sure the panel has far more value to bring to the discussion than I do. I did want to just set some high-level context, and in particular, not everybody is maybe as familiar with healthcare, but in Canada, healthcare is very much managed provincially, and the provinces all have different models, and the models have continued to evolve over the last number of years, and sometimes they evolve from one model to a different model and back to the original model. So it is an industry where there's lots of change, and politics finds its way into healthcare inevitably, not just probably in Canada, but everywhere. One of the key challenges is just the diverse number of stakeholders, many of whom have differing perspectives on value, and often with incentives that are not aligned. For example, patients usually don't care what the cost is, and they want to be treated close to home, but that isn't always financially or clinically practical. It also means that change is very challenging, especially where structure doesn't support the change and or where government is not prepared to mandate change. And so often in healthcare, you hear words like collaboration, because that's many times the easiest path to engage stakeholders and to drive change. And Plexus is a good example of collaboration between a number of hospitals. who created and use a shared service organization to manage and deliver their supply chain so they can focus on treating patients. And we deliver our services through an integrated model, and that includes managing the flow of products from the supplier right through to the nursing unit where they're used, sourcing across a broad scope of spend categories, both products and services and capital. We do transactional purchasing and accounts payable processing. And for some of our hospitals, we provide their financial system that also includes business intelligence and analytics. And so just before I turn things over to the panel, I just want to set some context in particular around the landscape in Ontario today. We're all striving for value for money, but there are certainly lots of things going on, and it would be remiss if there wasn't anything that people talk about today that doesn't talk about the pandemic. The reality is, I think we probably spent the first year of the pandemic actually preparing for it, and the last year responding to it. And I think we're now, in some ways we think we're coming out of it, but I have never, ever in my career seen the number of global supply challenges we have today, the number of items on back order, the fluctuations in demand and the challenges that creates, unprecedented in my career, not just in my career at Plexus, but in my career period. We also in Ontario still have a pretty siloed structure, and there are multiple jurisdictions. And one of the things I think we've learned, in particular when it comes to policies, and some of this connects to the pandemic, but we have provincial models, we have models based in the various ministries, and there's public health, and even public health have different policies and models that all impact the ability for the supply chain to service the patient. And we've also seen capacity challenges. So we're also living in an environment right now where system capacity often drives decisions that get made because we don't have unlimited capacity. We have data challenges, and I think this really became clear when you start to look across not just the health system, but the province overall. And we don't really have data standards in place that allow organizations to easily interact and move data back and forth. We've got some initiatives that are underway, including the creation of a new agency, Supply Ontario, which I think now is actually about a year since they started Supply Ontario, and it has a broad mandate across not just healthcare supply chain, but the provincial supply chain. There's been a number of Made in Canada initiatives to try and provide domestic production, in particular focused on PPE. And a good example would be the 3M N95 mask factory that is in Brockville. That was a combination actually supported both by the province, but also by the federal government. And there are some initiatives underway to try and modernize the supply chain in Ontario. And Ontario Health teams and the evolution of Ontario Health and value-based procurement all around how do we drive value for money. Just a few moving pieces right now. And on that note, I'm going to pass it over to the panel and be really interested in hearing some of the discussion around and getting their perspectives. So I'm going to pass it over to Andrea, and really look forward to hearing you and really appreciate the panel being here. Thanks.
Great, David. Thanks. Thanks for that context. Important for our audience and to set up our panel here. And I think we actually have a sixth panelist. I can hear him barking in the background. So we're very pleased to have the panelists that we have here today. They've got terrific experience in the sector, and I think have a lot to add to our conversation tonight. So I'll introduce them. Dove Klein, who is Vice President, Value-Based Care at Ontario Health. well known in the healthcare sector, and then Robert Bull, who's the Vice President, Finance, Technology, and Innovation at Southlake Regional Health Center. So great hospital perspective, and a hospital that's very focused as well on Ontario Health Teams. Kunal Patel, who's Director of Strategy and Integration at Sunnybrook Health Sciences Center. So again, a terrific hospital perspective, and in particular from what Sunnybrook is doing in this space. Nicole DeCourt, who's President and CEO of MedTech Canada, and who represents the medical device and technology suppliers to the healthcare sector. And then David Graham from Scarborough Health Network, where he is the Executive Vice President and Chief Administrative Officer. So wonderful to have industry represented, government represented, and representatives from three terrific hospitals in our jurisdiction. So with that, I'll turn to the questions that we'd like to ask the panel, and I'm going to start with Dov. To really zero in on the Ontario Health Teams from his perspective. And so Dov, by way of context and leading us off here, how is Ontario Health supporting value-based care? And why is this important or critical for enabling Ontario Health Teams? We'll start with that.
Sure. Thanks, Andrea. And thanks for having me here today. I think this is my third or fourth year coming to this event, so very exciting. So Ontario Health, for those who don't know, is an agency that was created by the Ontario government a few years ago that brought together 24 agencies of government into one, what some like to call super agency. And I would say that kind of a challenging time to create an organization in the middle of a once in a 100-year pandemic. But despite that, we've done a lot of work and been very focused on trying to really bring a more integrated approach to how we look, or systems-wide approach to how we look at the health system. My role, particularly in Ontario Health, is trying to look at all of our sort of funding, data, and quality assets, and really start to look at a system-wide lens for how we look at value for patients and caregivers as they move across the system or experience their care. So there's kind of four areas that we focus on. The first is on funding. So starting to look at where can we unlock siloed-based funding in the system and start to create integrated pathways for patients so that you don't start to look at value for patients only in one sort of part of the system, let's say just in the hospital component versus home care or primary care or whatnot, and really start to look at a condition-based way. How do we integrate all of those services from a funding perspective in a way that matters for patients? Data is the other place that we're very focused on, and looking at all of our data assets to look at how can we start to reproduce them and provide them back at a local level for Ontario Health Teams and for providers. So that's both geographic-based reporting and what we call the attribution model, which is the ministry's way of linking patients to an OHT. So that's some very focused work that we're doing. It started in the pandemic by looking at vaccine and testing policy, which we looked at high priority communities based on postal code. And now it's looking at basically everything that we own from a data perspective. The third area is OHT accountability. So it's looking at both the governance and accountability components of where OHTs need to go over the next period of time, and figuring out kind of how do we bring leading practice to that area and work with the Ministry of Health, our partners, in implementing that. And then the fourth area is, and the last area is, how do we pay for the future of care? And so that's bringing a lot of our health economic assets and our funding assets to start looking at when we pay for big things in the system, big IT, big digital health, supplies and equipment. How do we start looking at their impact to the system over their true impact? So over the year of care for a patient, the experience of care for a patient, maybe their whole lifespan, versus how we look at things very often today in procurement, which is usually based in sort of the budget of the system player that's buying that product. And so Ontario Health sort of has an interesting role to play in that I can see the entire system and can help to sort of smooth out some of those business case challenges when the hospital might have to buy a particular product, but the benefits are accrued in a different part of the system. We have a role to play, I think, in being able to smooth that out and make those investments make sense and align better with the patient's experience of care. So that's the role, and that's what we're trying to do. It's still relatively new. We also have a VP of OHT policy and governance who's not here today, but there's a whole focus area within OH that's just focused on how do we work with the ministry around enabling Ontario health teams and finding more opportunities for care integration. Maybe just to give you one quick example, we actually launched yesterday an initiative in heart failure. So using the CHF QBP, or quality-based procedure, to start looking at how we liberate it or unlock it from within the four walls of the hospital, and then provide other funding to really look at the end-to-end pathway for heart failure patients and focus much more on prevention and keeping patients happy and healthy at home or in the community, as opposed to only paying for them when they show up in a hospital, which of course is the wrong thing that we want to pay for.
Okay, that's great. Thank you, Dov. It's really good context to have those four sort of key drivers or pillars that you're focused on. And I loved your perspective of the entire, you have the bird's eye view of the system. And so maybe just another question for you before I pivot to the other panelists. So looking at your priorities and your model, how are you sort of facilitating collaboration between the various parties and partners to support more opportunities for that integrated care?
Yeah, so the way we operate, so our operating model is that our regions are our front door to the health system. So they're closest to the providers, closest to the patient. And so our goal is to work as closely as we can with the regions to find where are the opportunities and how do we bring folks together to collaborate. At the end of the day, OHTs, there's now 51 of them that have been announced. All of them are entities that sort of stand separately, but also together. And we're really all just trying to give them the tools and get out of the way. Like, for example, the heart failure opportunity that I mentioned, right? How do we get out of the way of helping them collaborate by removing any constraints of funding or other things that might get in the way of collaboration? So I would say that's our focus. I don't think we need to insert ourselves more than really give them the tools and the context with which to do what they do, which is take care of patients.
Yeah. Okay, that's great. So I'll turn it now over to our hospital panelists, because they're obviously key, hospitals are key stakeholders and key partners in the health teams. And so I'll start with you, Rob. Is there anything you'd like to add or debate or challenge in terms of what Dov might have described?
No, I think, Dov hit the key pillars of it on the head there, and also highlighted some of the challenges. So, the one that I'll perhaps emphasize and leave other panelists to talk about other pieces of it is that, David mentioned, Dov followed up on, we do have a very siloed health system at the moment, and that translates into governance, translates into funding, translates into supply chain, which you hear about. Each entity within that continuum typically, will have its own supply chain partner, will have its own contracts with vendors, will have its own funding stream, and those things force you in some ways to think very siloed. So I think the benefit coming along with an OHT, if I speak purely from a hospital perspective, a hospital isn't funded to keep people out of hospital. A hospital generally is funded for the activity that happens within the hospital's walls. And so, but hospitals can have insight and input into what are other ways we could keep people out of hospital, whether it's before the hospital event occurs or after the hospital event occurs, and preventing them coming back. So I think that continuum, bringing people together, there's so far that voluntary will get you, and we can talk about different things, but fundamentally, until some of that, that funding piece changes and there's more fluidity, I guess, in the way that funding moves across the continuum, everybody will still be rooted somewhat in this is how we get funded and that's how you get funded. And so we have to align the funding with the incentives, because as Dov mentioned, in some cases, that the entity in the continuum that needs to make the investment isn't the one that benefits from that investment. And so we have to be able to do that. And sometimes that's not necessarily more money in the system, it's shifting where the money is spent.
Yeah, that's great points, Rob. I'm going to turn to you, David, and David Graham, and we've had these conversations before, both one-on-one and on some of these panels. And I know that you've often said that you're there for patients when they need you, but that's the last place where patients want to show up is in your emerge or on your doorstep. David, anything to add to what Rob and Dove have provided us so far?
I'd just say that as part of some of the OHTs, people have different ways of responding within their community. So part of what OH did in the creation of that, that Dove can attest to, is they really did kind of take a step back and say, look, it's kind of up to you and your organizations into how you would partner and make sure you're making solutions for your region. So from my perspective, when I look at this and say, how are we using OH and how are we using the OHTs to really be able to standardize care and to be able to take that journey, it's somewhat related to a comment that I'm going to jump in here about, where they talk about policing the cost. And what you're really trying to do is take that total value and take that total path of a process for a patient and really build that in as efficiently as possible with the best care possible. So when you look at how we police it within the Ontario marketplace, we are doing things like program costing that allows us to do there. What you would have as a difference between this and the States or an accountable care organization is that when you start to expand through OHTs and have the continuum of care from the time they start all the way through, you would have a true cost of what you were providing. So OHTs provide that opportunity so that you don't have handoffs, essentially. It becomes a seamless care path for that patient. And that's really where the value is, gets you out of that siloed and allows you to use your buying power across the entire continuum of that patient's care. So,
okay, that's great. Thanks for that, David. And Kunal, your perspective in your role at Sunnybrook and your experience in the sector.
Yeah, I think the 2 points that I'll just sort of maybe go a little bit deeper on is the governance and the funding. And I think we talked a little bit about it, but many OHTs, and our OHT at Sunnybrook is the North Toronto Ontario Health Team. Many of the OHTs have many partners, and many of them are in multiple OHTs, which just adds to the complexity. They have tiered memberships. They have all of these organizations working together in a trust-based exercise. There's not a single CEO that's able to make these decisions for these organizations or these OHTs. And so it just adds a little bit to the complexities. And I think to Rob's point about the keeping sort of aligning incentives, I think that makes the most sense. And it really comes back to the funding models. And to me, it's about defining a way to create shared risk across the various members within the OHT. And as a hospital player in this, I'm always cognizant of sort of being the big player in the room of home care partners and community health centers and primary care partners that don't necessarily have all the resources, et cetera, at table as well. So just some additional perspective I wanted to add there.
Yeah, that's great. Thank you for that, Kunal. I'm actually going to start with you for the next question, Kunal, to get us into the sort of supply chain perspective within this conversation. So as the Ontario Health teams continue to evolve and formalize their integrated system, where does supply chain fit in that picture, and how can it be helpful? How can it be an enabler for the value-based care that you're trying to create?
Yeah, great. Thanks, Andrea. I think one of the goals for the OHTs, and it's laid out clearly in their transfer payment agreements with the ministry, is to reduce sort of clinical variation across the care continuum. To me, it's about, Dove sort of alluded to at the start, taking steps to standardize product usage across the care continuum and not think of it in a silo mentality. It's important for the OHTs to engage various suppliers in sort of a joint manner, but appreciating that the suppliers need to be able to use that product across the entire care continuum. One of the key areas that the OHTs are working on is population health management. So we've all been attributed a certain population. And when we're thinking about supply chains, in my mind, we typically assign contracts or bids or award tenders to the lowest cost. And I know that that's not the purpose of value-based care, but the OHTs, I don't think are there yet. And to be honest, being on the front line of our OHT, this is not a top discussion point in terms of supply chain optimization. There are many other pieces to the puzzle that the OHTs are working on, but I think this is a really important one that, to me, is very exciting because it's ripe for opportunity.
Okay, agree totally. Thank you for that perspective, Kunal. David, over to you. Anything you'd like to add in terms of the supply chain perspective and being an enabler for what you're trying to accomplish?
Yeah, I would just go back to David's presentation where he outlines the different services that Plexus has actually done and how that we could leverage something that's already established across many organizations to actually leverage data and use information. So is there an ability to expand that through our continuum of care and our partners? So everything from data records right through to usage, I think that they could play a unifying role in actually making sure that smaller providers get something of scale that can go to them. When we look at these, clinical information systems, they become huge across, and even in our partnership with OHTs, we see our ability to scale health records with them gives them a real advantage. If we were able to do that on the same side of the procurement and the OHT path, to making sure that standardized care is accessible to them, it actually increases their ability to work through our systems as well. Even things through strategic sourcing, the product standardizations and the scale that would be available to them changes what they're able to do. When it came to the COVID response, Scarborough acted as a hub for them to actually make sure that we had services that we could store and keep for them, and allowed them to have providers in the community come and get them, and then stay connected in terms of our infection prevention and control as information change. So it actually creates more connections with your partners and allows you to share information even more seamlessly with them and actually plan responses together.
Yeah. Okay. Thank you for that, David. And Rob, anything you'd like to add to that question and the comments thus far?
I think the real potential and challenge with supply chain is around some of that level of product standardization. So I don't have an answer for you, but those of us who work in hospitals and work in supply chain will know trying to get standardization even within a hospital is really difficult, and within one hospital for certain devices, and now expand that across hospitals or across home care.
Yeah.
And you see some of the challenge. So, a common example that comes up all the time between hospitals and home care is wound care products. And we look for standardization whereby, a patient's been on a particular course of wound care in the hospital. Now they're discharged home, and the home care provider uses something different, and that sort of can interrupt the care, can waste some product. And now you think about, we have Scarborough and Sunnybrook on the call here. So between the three hospitals with three different OHTs, I don't know what our status is, but we're probably not standardized on that product. And now you think about who the home care providers are in our OHTs. We probably have some different, but some the same home care providers in our OHTs. And you look at if home care provider standardizes, let's say with Scarborough, could be the same home care provider might say, but we need something different to match up with Sunnybrook, and maybe we need something else different to match up with Southlake. And the reality is we're all dealing with, we all have different contracts with different providers at different prices. And so how do we get at some of that, standardization? Because even if we standardized within the Southlake OHT, that doesn't mean it's the same as the Sunnybrook one or the same as the Scarborough one. And to Kunal's point, we'll have some providers who belong to all three having to maybe do things three different ways that's different to the way they did it before. So I think that's where some of the opportunity, but it's a really complicated problem, as everybody who's tried to standardize something like hips and knees will attest to. It's not easy to standardize, particularly when you're going now multi-jurisdictional and multi-provider.
Yeah, that's a really interesting perspective, Rob. It's not just within the OHTs, it's across the OHTs. And Dov, you talked earlier in your opening remarks about Ontario Health sort of having the bird's eye view. So as the hospitals in these forming OHTs are trying to work with their partners and do what's right for their OHT and for the system at large. Do any of you have perspective on governance? Because I know, Kunal, you made the comment that there isn't a single CEO, a single decision maker at the end of the day who can make decisions in terms of this network, this collection, this web of partners within a team. Do any of you have perspective on governance for good decision making in the models that you're building? And we recognize that supply chain isn't, your top priority in your Ontario Health Team formation, but it's clearly a service that's important to its operations. So what are your thoughts on governance and decision making?
Is that for me?
Well, you just responded, so you're up. Yeah, thanks, Doug.
Okay. Yeah, so I mean, governance, I'll talk about it in two ways. So as already noted, governance is a challenge in the OHT model. There is some direction from the ministry about governance related to a single organization that holds sort of the TPA or the transfer payment agreement to set up the OHT. And there's a collaborative decision-making process that's supposed to be in place. But I think everyone recognizes that more guidance from the government is required, and that is going to be coming. I can't say when that's coming, but it is something the government has committed to bring forward. And ultimately, it has to provide a lot of what's already been mentioned, which is how do you have that shortest shared risk perspective, and how do you make a decision ultimately that will enable the patient to do well as they experience their episode of care or experience of care, but allow no one to be sort of shortchanged, so to speak, in that transaction for that patient. So that's something that has to be addressed, and it's I think, quite frankly, obvious that it's a problem and has to be dealt with in short course. That's all I got for you today on governance.
Well, the other thing you gave us earlier in your commentary, which I made a point of writing down, it's going to be a quotable quote from you, Dov. Our job is to give the tools and then get out of the way. So we'll look forward to more tools in the area of governance, because I think
part of that though is them giving us some guardrails as well.
Right.
And to Rob's point, when we talk standardization and you talk governance models, there has to be a clearly accountable piece to that. Micro situation, like I'll relate, and you're very familiar with this, Andrea. When we were looking at standardization at a single organization, we had 3 SKUs for gloves within the organization. So that on a micro piece, you can start getting your hands around how the governance worked to resolve that, and we did. You have to start expanding that. And to Kunal's point, if you have multiple partners within the OHT, but they have different outcomes and they form differently, I think you're going to have that when we start to standardize why we're managing OHTs and start doing at the vertical integration as opposed to horizontal. You might start getting to the point where you're able to define those goals, and that might lead to a governance structure that allows you to optimize them. But it's too early now.
Yeah, I think your point's well taken, David. And I think in the absence of governance, the incentives at least have to be in place to what's the right word, enable people or encourage people to make the right decisions, right? So I'm going to move on unless anyone else from the panel wanted to weigh in further on the topic of governance decision-making. Rob?
Yeah, just on that governance, just to reiterate some of what's already said, I think with that, voluntary only gets you so far. At some point, the rubber hits the road and tough decisions have to be made. And that's where more direction, I think so, at the end of the day, somebody has to be in charge, otherwise nobody's in charge. And voluntary and coming together and all wanting to do well, frankly, it's great in the textbook, it's great in ideology, but it often will fall apart when tough decisions need to be made and money starts to have to be shifted around, but nobody wants to give up. And frankly, within the OHT partners, there's different motivation, there's different business drivers, different motivations in terms of, are we all just trying to break even, or is everybody trying to make margin? Is everybody trying to make the same margin? Well, that's different depending on the players within the OHT, within the Ontario Health Team. And so I think it is that accountability. If we think even about accountability agreements that exist today, whether they're hospital accountability agreements or multi-sector accountability agreements, they're still largely quite driven by inputs, like number of volume, how many hips did you do, how many knees. There's a little bit in there about wait times, but quality and outcomes isn't really a driver for accountability or a driver for funding. And so until we haven't figured that out, or at least not implemented yet, even at the hospital or multi-sector level. So we have to get there for the OHT, to David's point, so that people can coalesce around a goal and around an outcome, and then drive to that outcome. And there has to be accountability, risk reward to meeting it or not meeting it, in order to, I think, somewhat force some of these conversations and tough decisions. Otherwise, it's, like I said, voluntary is nice, but it only gets you so far.
Yeah. Thanks for Robin. I think that's actually a good place to pivot to the next question, which is, when we think about the Ministry of Government and Consumer Services and Supply Ontario, they're rethinking supply chain for the province in order to drive a number of important priorities. What do you think is most critical to be addressed by MGCS and Supply Ontario to support your Ontario health team? If the question was posed to you, what's the one thing you'd like Supply Ontario and MGCS to know and to consider to facilitate your Ontario health team? What would you tell them? Maybe David, I'll start with you.
I'd like them to do an exercise of critical resources and sourcing of where they are. When we really tried to help our team through our OHT, that include things like long-term care and all of those types of organizations, they actually lacked just supplies that were of the most basic but absolutely required pieces, everything from Clorox bleach right through to masking. So part of what I would like to see is that list established of critical infrastructural needs for an organization to run, and then start actually making sure that you've got supply chain abilities within our borders, within our control, and start identifying those types of things. And that can be everything from the drug supply chain right through to, like I say, N95s and masks.
Right. Okay. Canal, what would you like to say to Supply Ontario and MGCS in support of your OHT?
Yeah, it would probably be maybe informing them that I think our OHT needs the better data, and I think Dov alluded to that at the start. Yeah. I think that's sort of the competitive advantage of the OHTs, if the ones that are going to be successful, the ones that have a better understanding of how much their supply chain costs, how much it costs them to run a patient through a pathway, because a lot of that information isn't available, not even within individual hospitals, despite the hospital being probably the most well-resourced party in the relationship. And so without some of that basic information, it's a blind spot for us and in the OHT. And I don't know how MGCS or SO can help with that, but just more of a flag to them to say we're working from a position of a little bit of weakness in terms of the types of data that we have to accurately understand where the opportunities lie in our OHT.
Yeah, and to drive good decision making, right, based on data. So I certainly know that from our conversations and interactions with both MGCS and Supply Ontario, data is very, very high on the radar screen. Exactly to your point around, providing data to provide good information to make good business decisions. So yeah, and Rob, did you have anything you wanted to add to that?
No, I think my fellow panelists kind of covered the thoughts I had in my head. So I have nothing enlightening to add to what they've already said.
All right. Okay. Thank you for that. So I want to turn to Nicole, who's been patiently waiting and listening. And Nicole DeCourt, as I introduced earlier, she is the voice of medical device suppliers on this panel this evening. And so, Nicole, in terms of what you've heard here this evening and what you've experienced in your role in this sector, how is industry strategizing and preparing to meet the needs of the Ontario health teams in a way that drives value for patients and the system?
Thanks for the question. And so as an industry, the medical device industry is really looking forward to the role that Ontario health teams are going to be playing in the healthcare system. And I'll say I've been following the chat as I've been listening to the panelists, so I might put a couple of things into context here based on some of the comments in the chat. But we think that Ontario health teams are going to have a pretty significant impact on the way the health system procures and thinks about medical technologies, right? So right now, each element of our healthcare system looks at medical technologies really just through their own lens. And just to take that a step back, right? So just in the way the system works and how we're moving with Ontario health teams, you know, primary care providers look at care from their lens, you know, family doctors and their budgets. Hospitals look at things through their lens and their budgets. Community care or home care agencies, the same thing. And what an Ontario health team does is it takes all of those different providers of health services in the healthcare system, puts them under one umbrella when they're looking at patient care, and puts the funding under one umbrella, just sort of generally speaking, because I saw a lot of questions about Ontario health teams and what they are and what they do. And so that's going to shift the way we look at medical devices. And what I mean by that, so for example, if a medical technology that would be normally purchased by a hospital and used by a hospital might help save money or create efficiencies in community care services, but it's going to cost the hospital more money, and that might be a challenge right now for a hospital to make that investment. Or if a technology is used in community care might, say, reduce the chances of a patient needing to be readmitted to the hospital after surgery. They might not be thinking about making those investments if ultimately they're not going to be responsible for the care of that patient when they get readmitted to hospital. So these are kind of simplistic examples, but right now, generally speaking, the system is designed to incentivize the primary user of a medical technology to view and value that technology just through their own lens, as opposed to through the lens of the entire patient journey. And since Ontario health teams are going to be responsible for that whole journey that a patient goes through from start to finish of whatever's going on with them from a healthcare perspective, both financially and through a patient care lens, that's going to mean that the system's going to look at medical technologies in a totally different way than they do now. And that's not only great for patient care, but it's also great for the health system as a whole. It's definitely going to change the approach of the medical technology industry when we're trying to bring new technologies and innovations into the system, because we're going to want to have those conversations about how, as a group, all the partners in the system might want to think about making an investment from a holistic sort of thinking on a patient care journey, instead of just looking through it from their own lens. So I think it's going to be a big opportunity for the healthcare system.
Okay. So I have a question for you. I have a question actually for the panelists based on what you said, Nicole, because we've talked a lot in many of these conversations about the patient continuum and standardization and appropriate funding. So maybe I'll start with you, David. So David, when we take, you mentioned gloves, you know, if we take gloves to market again, and we take gloves to market versus Supply Ontario or MGCS, would you see your partners at the table in that sourcing activity, or do you see yourself doing that on their behalf?
I'm always open to people who want to participate. So that would be my first piece. But I think the first part of that is maybe you start leveraging the hospitals, the bricks and mortar, to coordinate those meetings for the standardization process and discussion. And then once you build that trust with your partners, you're able to act on the behest of that group. I think when you're looking at an organization like Plexus with the size and scope that they have, having every OHT partner at the table, we would never move anything strategically forward. So I think you have to be able to identify those who have the best skill sets and the best abilities. It's not always going to be the hospital. And you got to be really clear in that and make sure that people start feeling comfortable that it's part of an overall system with accountability and make sure that you drive the accountability and the responsibility, not just open participation, my view.
Okay, thanks for that. Canal and Rob, what would you add to that? Anything different?
Go ahead.
No, I think David captured. I think certainly the opportunity could be there for for somebody to be the central coordinator for some of these things. But the challenge that we then run into when we're talking supply chain, we get contracting is part of it, and then the other part of supply chain is, so let's just say we land on the same provider for whatever it is, gloves, wound care. Now the other part of the supply chain is those gloves getting from the distributor's warehouse to the hospital, to the home care. For a hospital, it's straightforward. It goes on a truck, goes to a distribution center or to the the just-in-time provider, and that arrives at the hospital loading dock, and the supply enters into the walls of the hospital and gets distributed. Now we're talking about community agencies. We're talking about primary care. There's that element of the supply chain where you're having, okay, so how does the stuff get to those people, and is it the same distribution channel? Is it a different distribution channel? Is it priced differently now because that's getting more complicated? So a simple example we had with the during the pandemic, the hospital generally was able to get its hands on certain supplies easier than primary care was, and some of our community partners, both because of our purchasing power, but also our connections, and we're generally better resourced and have better availability for product. So we acted as a bit of a central hub to be able to get certain supplies for our primary care partners and others in the OHT who couldn't get them through their normal supply channels. But to the point I just made, then we got into how do we get that stuff? We have it at the hospital loading dock, or we have it in the hospital's distribution center. How are we now, are we now going to individually courier it to all these different offices? Are we going to say, we have it, come and get it from the hospital? There were those logistical challenges as well. So there's when we talk supply chain, we're talking about the continuum, right from signing on, choosing the product, signing on the contract, and now we're getting into distribution of how do you get it in people's hands?
Yeah, I appreciate you saying that, Rob, because it's true. We tend to focus first on sourcing, but there's a whole continuum that has to be thought through, including the physical part, obviously, of supply chain. Nicole, I just want to pivot back to you for a second, because you gave us the perspective on where things are used in the patient continuum and funding, et cetera. So your members, large, small, medium, and large suppliers, how are they strategizing in terms of how they interact with us in supply chain and in the system, given how the system is evolving?
Yeah,
go ahead.
That's a great question. And so there's a part of this that's around, and actually a lot of this is around collaboration, right? And having an open dialogue and being able to talk about how do we get the right tools in place to be able to procure and bring in technologies, looking at it from sort of a value-based procurement lens, and how we think about doing that. On the piece about collaboration, I can't stress enough how important this is to figure out how we create an infrastructure to have an open dialogue, right, between Ontario Health Teams and Ontario Health and the medtech industry. And I'm going to use an example from the pandemic that is sort of separate and outside of the world of Ontario Health, but just to talk about why collaboration and that open dialogue is so important. So when the pandemic hit, one of the big challenges we had in Canada, and I think this example will resonate, everybody, can see all this happening, was COVID testing, our capacity and our ability to do COVID testing. So we as an industry, we reached out actually to the federal government to let them know that they should bring industry to the table just to see how we could support them with their, with their needs. And in this case, even though healthcare is usually a provincial jurisdiction, the federal government was actually playing a pretty big role coordinating all of the province's efforts. So we set up a table. It still meets every 2 weeks between our MedTech Canada members who are in the diagnostic and testing space with Health Canada itself and the Public Health Agency of Canada, which is known as PHAC. So at those meetings, PHAC and Health Canada would walk us through the various challenges they were having, whether it was access to supplies like swabs or reagents, shortage of lab technicians, issues with the time lags from sample collection to test results, and a whole slew of other challenges they faced during the pandemic. And our members were able to help beyond just being companies that they bought stuff from. We played a much bigger role. So we were able to get a better sense of their needs and bring to them solutions and ideas to help support the challenges that they were having with health human resources, or by bringing point of care PCR testing to the right places like remote communities or long-term care homes, that swabs didn't have to be transported to labs. We found lots of innovative ways to help. We were also able to share with them best practices from around the world, since most medtech companies operate in countries all over the globe. So this helped inform groups like the Federal Expert Panel on COVID-19 Testing and Screening, they've been releasing reports throughout the whole pandemic to provinces on things like rapid antigen testing and the best ways to benefit from that technology. And in the case of rapid tests, we brought them use cases from all over the world on how we can use rapid antigen tests as a screening tool to catch COVID-19 cases in people who are asymptomatic, as opposed to using it as a tool to diagnose someone with COVID after they're very clearly sick. All of that collaboration led directly to Canada's ability and capability to respond to the pandemic from a testing perspective. And I know we've had challenges along the way in Canada on testing, but we've done quite well overall, and we're still seeing the results of those collaborations today. So as provinces are rolling out, for example, more and more rapid antigen testing directly to the public. So I know I've gone a bit off track from Ontario Health Teams, and I'll bring it right back to that. I think one of the, when we talk about strategizing, it's really about getting those collaborative tables in place so that Ontario Health Teams can share with the medtech sector what their challenges are from a patient care perspective and from a health system perspective. Industry can have that dialogue on the technologies and innovations that can support patients across that continuum of care. And we can work together to help bring innovations and technologies into the system that can help with these challenges. The medtech industry is really eager to show the value that their technologies can bring to the system. So we need to focus on bringing together the concept of value-based healthcare, which the Ontario Health Teams are trying to do, and the concept of value-based procurement as we integrate all of this into our healthcare system. So that's kind of when I think about strategizing, I really think about, it's about getting that infrastructure in place to have those dialogues and to have that communication and change the way we think about how we do procurement today.
And so Nicole, I'm going to take you up on your idea. Do you have a sense of how you would initiate like what would be the first type of collaborative table you would want to potentially suggest to be initiated?
Yeah, that's a really great question. And I mean, we've all, I think everybody on this panel say everybody's been consumed with the pandemic and the pandemic response. I mean, we've had great relationships with Ontario Health and the Ministry of Health, and our members have great relationships with hospitals and all the different players in Ontario Health Teams. So I actually think that is one of the first conversations we need to have is, now that we can start to wrap our heads around where Ontario Health Teams are going to go and how they're going to evolve, one of the first conversations we need is how do we set up, what do these conversations look like, and what works for the Ontario Health Teams as well, and all the other stakeholders involved in the system, procurement groups and others, right? So I just say, I think with the pandemic, it's been really challenging to wrap our heads around exactly where to start, but
for sure. But I think, I mean, I think all of us would, in concept, comment that a collaborative table is a very good, constructive idea. And maybe one of the action items I can give you out of this panel is to come forward with a recommendation, and if you like, you can come to Plexus and, we can have that conversation, or you can reach out to a hospital. But I think it would be great if industry came forward and said, to your point, look at all the great conversation we had around testing and the actions that led to. Is there something that we can replicate in this context? that would be initiated by industry. So, would welcome you to come back with some ideas around that.
Absolutely.
Okay. Rob, Canal, and David, questions for Nicole, who's representing the entire medical device and technology industry in Canada here tonight, in the context of supporting you.
I just had one question for Nicole. Nicole, I mean, we've created 51 new targets for you to come after and sell product to. How are you specifically, minus this table, like you can't feasibly be going after 51 individual OHTs, right? Or am I not following?
Yeah, no, I think that's that speaks also to the role of Ontario Health and Supply Ontario, and groups like Plexus, who I think have an overarching role across all of the Ontario Health teams. And I think in some ways that's where some of those conversations have to start, to figure out how to do better coordination across the whole province. Because you're right, that is, that now that's 51 conversations, but before Ontario Health teams, you're talking like individual at the hospital level conversations as well, right? So it's getting better as the Ontario Health teams are created, but Ontario Health and Supply Ontario have a big role to play here.
Okay. Rob or David, anything you'd like to direct to Nicole?
I just always think that organizations and partnerships happen and coalesce when you come up with a solution-based approach. So maybe the conversations really start to say, well, what problems did we identify, and what are we trying to solve, and then how do we leverage within each other? So
yeah, good. Rob, anything to add?
Well, I'd say probably, a comment, and maybe there's a question in there somewhere, but I would say, for the medtech industry, that probably the advantage with an OHT is maybe you're still speaking to the same people, but the conversation can be different now. Because I think previously, I use the viewpoint of a hospital, and we still see it today. I think, a lot of providers, and particularly when we see this with entrepreneurs and new entrants to the market, or people from other jurisdictions coming in, they don't really understand or appreciate just how siloed the current system is. And so they try and sell to the hospital this complete continuum of care solution. That's great, but the hospital's going to say, but I'm not going to pay for all that, because 60% of it is, not nothing to do with the hospital, but is not really anything to do with the hospital. That's, that's primary care, that's post-acute care. And so I think some of those conversations now, maybe it's the same product and you're speaking to the same person, but you can now do it in a much different context and probably have a better and more realistic conversation now that I'd say more of the continuum has opened up.
Yeah, I'd agree.
Yeah. So I think, Nicole, great input there from our panelists, and I like what David said in terms of, if you go away and think about how to have a collaborative table, it really starts with pick one of the many problems we're trying to solve, and maybe start with one. Okay. Now I know we want to pivot now to questions from the audience. So a lot of valuable and different perspectives from Dove at Ontario Health, from our three representatives from the hospitals, as well as Nicole from industry. So Rosemary, can you perhaps take a look at the, I think, 42 questions or so that have come forward, and just maybe give us the first major theme by way of question we might want to address by the panel?
Yeah, thanks, Andrea. There's been many questions and some themes have definitely emerged. I'd say one that's come up is this whole question of standardization versus patient choice. So in your comments so far, you've been talking a lot about, that goal of standardization, and a few people in the audience are wondering, okay, well, how do you balance the need to keep providing choice to patients and responding and renewing, and not maybe locking in to particular products or services without allowing for that patient choice to continue. So I'd say that's one theme that perhaps the panel
Okay.
can comment on.
Yeah, thanks for that, Rosemary. So I'll turn first to our hospital panelists, because you are, in front and center in delivering patient care. So Rob, would you have a perspective on that with regards to the question?
Yeah, I think, for the most part, when we're talking about standardization and patient choice, I think there's a couple of different things. One, patients somewhat have a choice today in terms of maybe which hospital they go to or which surgeon they go to. So certainly a patient, when you need emergency care, depending on where you live, I think generally your choice is, well, where's the closest place, and I'll go there. But in terms of, if you go and see your family physician and you need a referral because you're heading down a path of some kind of surgical intervention, maybe you have some choice, giving birth. I know people like to choose sometimes which hospital I go to, want a newer one. So I don't think, any of that kind of choice would get interrupted by anything to do with an Ontario Health team. It wouldn't be like, an accountable care organization where you're trying to be kept in contract or kept in provider. We wouldn't be that kind of relationship. The kind of standardization we've been talking about really is about, what gloves, what sutures, what bandages, what, devices, what implantables are used with a patient, which generally, I think today patients don't really choose, or I suspect for the most part, don't really even think about or care, what bandage am I being used, what suture was used to stitch me up, what knee replacement did I have a Stryker, did I have an Oxford, did I have a Zimmer? I think those kinds of things generally patients don't really choose today. Like I said, or frankly, are that bothered, I don't think, about what gloves get used on them. So that's really the kind of standardization we're talking about. An OHT, although we tend to think about them like an accountable care organization in terms of coordinating the care, we don't think about it like an accountable care organization would in terms of, like I said, keeping you in the family, keeping you in the insurer, that kind of standardization. That's not what we're thinking about with OHTs.
Yeah, thanks for that, Rob. Kunal, do you have a perspective?
Yeah, Rob said pretty much what I was thinking. I don't think patients, maybe I'm overstating here, but really care or value what kind of suture they get. And so I agree with that. But there is a concept that Rob also alluded to is, we're not ACOs. We're patients will have a choice of which OHT they sort of use services from. The OHTs, while we have an attributed population by the ministry, that doesn't mean that they can't access services from another OHT, which creates confusion more so for the OHTs than it does perhaps for the patient, because we're accountable financially and clinically for a set of patients, and that's what we're measured against. But that patient has complete choice and freedom to go to any OHT they would like and receive the services they would like, as Rob sort of alluded to. So, but no, I have nothing more to add than that. Thanks.
Okay, thanks, Kunal. David, anything you'd want to add?
No, I agree with everything that's been said.
Yeah. Okay. Thank you for the question and for the responses. Rosemary, what else would you like to put on the table?
Well, a few more things here coming in. I thought interesting question from Neil Fraser. He asks, will procurement professionals have to retool to understand the full patient journey through multiple silos to understand quality, outcomes, and value? So I guess that's a question, how might procurement reorient? I mean, it's a theme that's come through many of the comments, but a bit more focused.
So as a supply chain person on the panel, I think I will defer first to other panelists. And then if time permits, I might provide perspective. So Kunal, what would your view be on that question around, how does procurement need to
and I'm definitely not the procurement specialist here either, but I think it comes back to me, the question you asked David about those gloves, like we're not, I was thinking about that question a bit more. the hospital would sort of make these decisions in sort of isolation, which glove is the best. But we are not tooled right now to even understand how to communicate what the home care, what primary care wants in terms of their needs and preferences. We can't even sometimes get our own hospitals aligned with what we want internally after many months of what kind of glove we want. And so to me, there's lots of internal discussions that need to happen on, how do we even have those conversations to start? Because I don't think, at least I've not seen a structure to support those conversations, but I'm not the expert here. So I'm talking out of turn perhaps.
Yeah, that's fine. You're our customer. You're the procurement customer. So your point of view is always very important. Rob, anything you'd like to add? I do have comments that I'll make at the end, but I want to give the panelists the benefit of responding first.
Well, I think my short answer is yes. I think there is some, retooling and things that will go on. I think part of that, though, goes back to one of our very first discussions about funding, which is that previously, when we talk about value-based procurement, we talk about procuring across the continuum of care. It's not that people didn't think like that before, or weren't smart enough to think like that, or couldn't think like that. It's that even if they did think like that, the accountabilities and the funding mechanisms don't support that. And so even if you thought that and really wanted to do it that way, it took a hospital's leap of faith or commitment to say, maybe this isn't in our financial interest, but we're still going to do it anyway. And it will take a bit of getting used to, I think, and a bit of thinking differently. But I think some of it's not that people can't think like that now, it's that the system isn't set up to enable that. And that maybe is the change that will take a little while, that if the tools and systems are in place to now enable that kind of across the continuum purchasing and incentives align with actions, that maybe is the key to unlocking this, versus all of a sudden people need to get smarter and think differently.
Okay. All right. David, is there anything you'd like to add?
I'd just say that any service organization, they have to understand the core services, and in order to efficiently and effectively service their customer base, whether it's finance, whether it's procurement, whether it's payroll, you absolutely have to immerse yourself and understand the business that they're providing. When we talk Plexus specifically, I think that's an example where having them on site and being part of those discussions, I think that they've already learned and been part of that organizational change. So this would be the next evolution of that. But I am curious about your thoughts, given we've had many discussions. So
yeah, we have. Yeah, so thank you, Neil, for asking the question. I think that procurement professionals are retooling every day, all the time, because the sands are continually shifting, and any procurement needs to be addressed like it's the first time doing it. Whether we've been to market 10 times for hips and knees, every time we go to market, we come to the table with the customer like it's the first time, because their needs might have changed, their patient population might have changed. So it all starts with understanding the customer's needs, which in this case is primarily the payer, so the hospital in this case for Plexus. I think in terms of moving forward, ideas like Nicole's of having a collaborative table. Do you have representation from across the Ontario Health team or teams as you go to market for something for the province, so that you make sure that you have stakeholders at the table who can represent the full patient journey across the silos. And then I think you have to learn from the experiences. We've learned so much over the last 15 years that Plexus has been in existence. We're going to market differently today than we did 15 years ago, because the market has shifted, the hospital needs have shifted. And I think the best example we probably have is when we went to market for the province for ICDs and CRTs. 12 centers in the hospital, we got them together. And, they were from all different parts of the province. Not necessarily had they all worked with Plexus before, but, we ran a provincial table, we ran a provincial exercise. And I think what was most exciting in that experience is we had patients We had patients as part of the process. We had a patient focus group who brought extremely rich and valuable input to the table for the clinicians to consider and for the administrators to consider. So I think we've already cut our teeth with some examples of doing that, but I think we're all learning as we go. So, you know, I would say that procurement professionals are continuing to retool in adapting to the new environment, and have already got some examples of where I think we've done that really well. So I think we have a good foundation to build from. Okay. So thank you for the question, Neil. Rosemary, I'm looking at the time at 6:10. Would you like to wrap us up with closing remarks, or did you want to take another question? I'll take my orders from you.
Well, I think we have just a couple more minutes, and maybe I'll squeeze in one last question. And Joshua was asking about the biggest lesson learned from COVID. So I know David mentioned that in his opening remarks, but perhaps we could ask maybe a couple of the panelists just to say, what has been the biggest lesson learned from the COVID era? Will certain things in healthcare supply chain be done fundamentally different in the post-COVID era?
So I'd like to pivot first to Dov. We haven't heard from Dov in a little while through the last couple of questions. And I know that Dov was intimately involved, and you have that bird's eye view of the system, Dov, as you referenced earlier. Maybe you could be the first to answer that last question for us.
Sure. So I think probably the biggest lesson learned, and it's not that we didn't know the lesson, but COVID certainly brought it to light, was, you know, while we might act as different, you know, providers in a system of systems, right, with lots and lots of silos, at the end of the day, we are one system, right? We're at the end of the day, when you have COVID patients coming in across the system, there's one group of ICU beds, there's one group of hospital beds, and ultimately, from a supply chain perspective, there's one bolus of resources. And when you have global supply constraints, in particular across the world, not just across the province, you have to act like a system. And one of the greatest things that I've been involved in over the last 2 years is seeing different providers who may never have worked together before, or maybe not worked well together before, sort of put down whatever happened previously and, you know, share resources, you know, open up beds for other systems that were overwhelmed. And, you know, we were, you know, wave 3 in particular, moving 1,000 patients across the system to wherever they needed to go based on the requirements. And particularly in supply chain as well, it's so obvious, right? And you actually think even pre-pandemic, how there were so many things that, you know, there's so many stockouts and so many other issues that happened based on global supply chain challenges. COVID really brought that to the forefront of how we operate on such a razor's edge, so to speak. And, you know, fundamentally, and I hope we don't forget the lessons of COVID as we hopefully come out of it, fundamentally, we have to think like a system, and we have to be putting in the right amount of redundancy into the system so that we don't end up in another situation where we're running out of product or we're really scrounging around for different pieces. But to the extent possible, to continue acting like a system would be, I think, the biggest lesson learned out of COVID.
Yeah. Very, very good point. So to the rest of our panelists, Nicole, what would you articulate as the biggest lesson learned?
Yeah, so I'll just say I could write a book on all the biggest lessons learned when it comes to the pandemic and our health system and supply chain and procurement. But I'm going to give a really simple example to kind of amplify one of the biggest lessons learned. And it'll kind of encompass them. Think about a mask. Okay, think about a mask and think about a world where you sole source the cheapest price mask from one supplier. What's the lessons we learned in all of that, right? So price, you know, looking at technologies from a price and economies of scale and all that kind of stuff, you know, you do that and you can end up with limited access to multiple suppliers, right? So when you think about value and value, you know, in supply chain. So, you know, diversifying your supply base and your supply chains and all that kind of stuff. You think about quality and you think about the impact of quality on patient care and patient health, and making the investments in, you know, something that is going to give a better health outcome for the user of that mask. And then you think about health system savings, right? So you translate that quality on a better quality mask, you know, in the context of a pandemic, and you're saving the entire health system significant money when you're reducing the transmission of the spread of COVID. So really, really simple thing when you think about, you know, the concept of just, you know, that action of buying a mask. But you can really translate that into a whole bunch of different lessons we learned during the pandemic when it comes to supply chain and value-based procurement and all the things we're talking about today.
Yeah, thanks for that, Nicole. Rob.
Yeah, I was actually going to say something, and it picks up on what Dov said, and ties back to some of my earlier comments with OHTs. So Dov is right, phenomenally successful in thinking like a system during the pandemic, in the way that thousands of patients moved around the system, between, you know, I'm speaking from a hospital perspective, moved between hospitals, so that those in trouble could be relieved by those who weren't in as much trouble. But I go back to the earlier point, is in order for that to be enabled, it took central coordination and somewhat forced by Ontario Health, by a central coordinator. And there were two real key enablers to that didn't exist prior to the pandemic. One was the issuance of Directive 2, which was the one that told, or effectively forced, mandated hospitals to stop activity that wasn't surgical procedures that weren't urgent or emergent, which created the capacity in the first place. And then it was the creation of a central command table that effectively ordered hospitals to take patients from receiving. It coordinated centrally the sending and receiving of patients. And that was, you know, if we want to call it mandated or, you know, centrally coordinated, that wouldn't have happened voluntarily. And there would have been some level of voluntary, and there are mechanisms pre-COVID, like critical and things like that. But generally, you know, a receiving hospital would be, well, we're full as well because we're doing all our procedures. It took that central coordination mandating to go beyond the voluntary activity, the voluntary participation, to say, you will stop procedures and you will stop taking patients from other hospitals. And so, as I relate to the earlier comments on OHT, you know, to me, it reiterates voluntary will get you so far, but it's not going to get you to the end goal. At some point, there needs to be, you know, effectively a forced or a mandated or a directive to get it over the line and really make it effective. Otherwise, there's only so far it's going to go. And so, to me, that was reiterated in the pandemic, where the system came together, but it was because Ontario Health or the government took a central coordinating role to force certain activity to happen or not happen.
Yeah, great point. David, let's hear from you.
I would just say, probably from a supply chain perspective, I think one of the biggest lessons is that we need to kind of reevaluate how we make decisions based on cost simply. And that when you see what happened in terms of our ability to actually get a hold of product and source product outside of our borders in a time of emergency, even our closest trading partners blocked exports to Canada. So I think it really is something that, as a supply chain, we need to reevaluate. It was a lesson that we learned with cancer drugs back when Dominican Republic and whatnot got hit with things. You know, how many times do we have to recognize that Canada isn't able to provide through our own borders some really key things, and really take those lessons and build it into, you know, critical care supply chain pieces. So.
Yeah. And I would add to that, David, you know, we really want to have a very healthy, competitive marketplace in Canada so that suppliers want to be here and stay here and be there for us in a pinch, because not everybody is going to have made in Canada or made in Ontario solutions, right? So we need to recognize that. Canal, any comments in terms of the question on lessons?
Yeah, sure. I can be quick. I would say I learned, you know, the hospital is no longer just a hospital. We were public health, we were vaccine centers, we were infection prevention, we were long-term care, we were everything for a lot of people. And supply chain is on that list as well. So I'm able to stop there, and from a very narrow perspective, that's what I took.
Okay, that's great. Thank you for sharing those lessons learned. And I think you're right, Nicole. You're in line with everybody else who wants to write a book on lessons learned from the pandemic. But I think the key takeaway is so many good lessons learned. And I think that's Angela from PwC, Angela Ma always says, don't waste a good crisis. So, as we come through it, we need to make sure that we embrace those lessons learned and carry them forward. And as a supply chain person, I can say, pivoting back to something David Yunt said earlier, we may be through the medical crisis of COVID, but we're still in the thick of, we're maybe coming out of that crisis, but we're certainly in the thick of wave 2 for supply chain crises. Just because of what all of the suppliers are telegraphing to us, from raw materials right through to delivering product to where it needs to be. So Rosemary, I think I'll turn it over to you then for closing comments.
Yeah, thank you, Andrea. Well, I know we're a little bit over time, so I'm just going to close us by saying thank you to all of our panelists. Thank you to David and Andrea for the facilitation. It's been a terrific conversation. And thank you to our audience for tuning in tonight. If you enjoyed tonight's panel, we have another one coming up, the last of our series on March 29th. We're going to be talking about the economics of primary care post-COVID. And I'll be posting that this week, so you can sign up where you found this event. So thank you, everybody. It's been, really wonderful to hear your points of view, and thank you for the questions too. We will be having a look at those that we weren't able to answer, and hopefully getting some responses to those whose questions weren't answered. So, all right. Thank you, and I guess I'll wish everyone a good night and a lovely evening.
Thanks, Rosemary. Thanks, panelists.